Okay, I'm back. Let me share my screen again and I'll put it on presentation mode. Okay. Uh, all right. When are we going to get started? I unfortunately,
Hi, Prof. Emmanuel.
hi, how are you doing?
I'm good. I'm good. Thank you so much for coming. So we will start in 2 minutes. We have one more speaker that's about to join. So we'll start in 2 minutes.
Okay, do I go
Yeah.
first or does the other speaker go
Yeah,
first?
he goes first.
Okay, so and I give
All
my
right.
talk afterwards.
Okay, so yeah, let's chill a bit.
Okay.
One more minute and we'll start. Thank you. So a very good evening to us all, wherever you're joining from. It could be good morning, it could be good afternoon, but we'd like to welcome you to the final day of the 2026 NISA Research Week. It's the icing on the cake today. And I'm going to introduce to us very special people that will take this session. First, I'll be introducing our moderator for today. And permit me to share my slide. Okay, so our moderator for today is Mrs. Hafsat Olufadi Ahmed. She is a senior associate researcher at CIDR, specializing in routine immunization, health system strengthening, and adolescent health. She designs complex mixed method studies, facilitates stakeholder engagements, and drives evidence-informed policy development. Her work spans peer-reviewed publications, research ethics, and capacity building, grounded in participatory approaches that prioritize sustainability and local ownership. So Aishat is going to be moderating the session for today. And for everyone, I'd like to mention and introduce myself. I am Professor Tonia Onyeka. I am the Associate Director of Ivan Research Institute, Nigeria. And we are having the final day for the NISA Research Week. I will not be the one to introduce the speakers themselves, but Aishat will be doing that shortly. Okay, so Aishat's having a little problem. Just hold on, let's find her. Can you raise your hand so we can find you where you are at? Yes, can you, is it possible? Okay, you've raised your hand. We'll find you. Thank you. Yes. So just give us a minute and Aishat will join us on the panel now. Yes. Welcome. Okay, unmute, please.
Yes.
Great. So take it over from here and welcome.
Thank you, Professor Tonia. It's great being here today. So good morning, good afternoon, good evening to everyone that is attending, our distinguished panelists, colleagues, and participants. We welcome you to day 5 of the NISA Research Week. It is themed Action and Accountability, Making Evidence Stick, Tools, Strategies, and Metrics that Drive Sustainable Policy and Practice Change. Now, over the past sessions, we have explored how evidence is generated, translated, and implemented. Now, today, we turn to a critical question that often determines long-term impact. What's this question? How do we ensure that evidence does not just inform decision, but also changes systems in a sustainable and accountable way? So we are privileged today to be joined by leaders working at the intersection of global health research, implementation science, and large-scale public health programming. We have with us Emmanuel Pepra, as well as Prosper Okonkwo, who is represented by Head of Research. So the first, yes, Emmanuel Pepra is an associate professor at NYU School of Global Public Health and director of the ISEE lab. His research focuses on implementation science, sickle cell disease, mental health integration, and global health partnership, advancing evidence-based interventions and community-engaged approaches to improve health outcomes locally and globally. Welcome, Mr. Emmanuel Pepra, Prof. Emmanuel Pepra. Now, our second panelist is Dr. Olabanjo Ogunshola. He is a public health physician and consultant with over 20 years of experience supporting large-scale projects in the design, implementation, monitoring, evaluation, and research of evidence-based programs. Over the past 13 years, he has worked with the PEPFAR implementing partner in Nigeria, that's APIN, to improve treatment coverage and outcomes for people living with HIV and to address common HIV-related comorbidities like cervical cancer. Dr. Ogunshola Olabanjo's public health focus has been on improving health outcomes for underserved and disadvantaged populations through implementation science. He's currently the Director of Non-Communicable Diseases and New Business Development at APIN Public Health Initiative. He serves as a principal. Welcome, both of you. Right. So the first speaker today would be Prof. Emmanuel.
Sure, happy to chime in. So thank you so much. So let me share my screen and I can share my PowerPoint as we speak. So let me go to the full screen mode. Can everybody see my PowerPoint slide?
Yes, we can.
Okay, fantastic. And I promise this will be short since this is day 5. Well, first, I really want to thank the organizers, including the Ivan Research Institute and colleagues at the Nigeria Implementation Science Alliance, NISA, for inviting me to this very important research week and also to wrap up the final day with me and my colleagues. So, as stated before, I work at NYU. I'm an associate professor, and I direct the IC lab. So, in terms of what I'm going to be talking about today's topic, making evidence stick, tool strategies, and metrics that can drive sustainable policy change. So, this is our lab. We are a global lab. We have various partners. We do work in Nigeria and other parts of the world. These are our links in terms of our public health stuff, our Instagram, and our email. So in my PowerPoint, I have 3 specific points. I'm going to really briefly cover why implementation science matters. I have no doubt that over the past 4 days, a lot of people have given you information on why it matters. I'm going to give it to you from my particular viewpoint or my lens. Then I'm going to really discuss the importance of evidence in implementation science and measuring implementation outcomes. And then I'm going to specifically talk about tools and strategies for making evidence stick, specifically what this session is about and something we have developed in our lab. So, just a brief overview. You've probably heard this before, but just to give you the contextual overview of implementation science. I like to use this within the classes that I teach in terms of implementation science to colleagues, to students here, whether it's in the US or in Nigeria, Ghana, or other parts of the world. And it just to give them an illustration of how long it takes to take evidence and actually implement it. And I like to use this historical perspective, which is discussing scurvy. Scurvy is a specific disease that was very common to many sailors in the 16 before the modern era, we could say. And specifically, it was discovered in 1601 that you could actually cure scurvy by the application of citrus. It wasn't discovered till over 100 years later that it was actually the vitamin C in citrus that was providing that sort of protection against that gum bleeding and all those ailments that were causing scurvy, because scurvy was due to a specific vitamin C deficiency. So in 1601, it was actually a case study that showed that citrus cured scurvy. However, it wasn't until 1747, over 100 years later, in which a randomized control trial to treat scurvy was conducted and showed equivalently that, citrus can treat scurvy. But yet, it took another 48 years to implement that evidence, right? So, from the initial discovery of citrus to its full implementation, it took over 100 years. So imagine that. It took over 100 years for when we knew something worked, specifically to prevent a disorder, to where it's being fully implemented, right? And scurvy is an important historical fact because it is the term where we get the term limey from. Limey is usually pejorative, which was shortened to specifically refer to British sailors because they would take lime juice and add it to their grog. And that lime juice was specifically to prevent scurvy. And that made British Navy one of the most powerful navies in the pre-industrial times. Now, of course, the person who did all this, James Lind, he is rightly venerated in English specific science, and there's a building that is actually named in his honor. And of course, this is the specific BBC News celebrating his life and his birth, etc., in terms of the contributions he made to science on behalf of the British people. And in fact, also in scurvy, there has been books written about how this evidence was generated by Lamb, how it was lost, and had to be regenerated again in terms of those 100 years. So it's a very interesting story, right? So, but this points to a specific issue that exists. The lack of uptake of clinical innovations. Now, these clinical innovations can be new interventions, even new treatment modalities, new treatment technologies, and even new organizations of treating individuals with specific conditions. All of these constitute new innovations. The lack of adoption of it is a centuries-old problem. In our modern pace specifically, we have so much literature in terms of the various disease treatments, etc. So, our modern world, the rapid pace of modern biomedical research has really outstripped our absorptive capacity. So, not only scurvy, we have examples in terms of smallpox vaccines, penicillin, insulin, antiretroviral therapy for HIV/AIDS, and most recently, COVID-19 vaccinations in terms of vaccine hesitancy. So these are examples, and there are even longer list of examples of how there is evidence about evidence-based interventions, but there is lack of uptake, right? So what is clear is that establishing the effectiveness of a clinical innovation is not sufficient to guarantee uptake. Just because you show that something is effective, there are so many other factors that really affect its adoption within clinical and real world settings. And that's where science comes in. I have no doubt that you've probably seen these quotes before about Eccles and Mittman talking about what implementation science is, which is the study of methods to promote the systematic uptake of research findings and other evidence-based interventions into routine practice. And then that should improve the quality and effectiveness of health services. So, as an implementation scientist, I don't establish the effectiveness of new and of innovations. I look at that overall impact and identify factors that affect its uptake or adoption into routine use. From my perspective, implementation science falls into three main branches, right? And there is the implementation research aspect of it, which you're trying to figure out how you can get these evidence-based interventions adopted. There is the de-implementation research aspect of it, which is a newer field that has come out of implementation research. De-implementation research just specifically means how do we de-implement ineffective or sometimes harmful uh, interventions that exist? So if you're thinking about you need to implement something, you're probably having to also de-implement something that's also existing at the same time, right? So implementation and de-implementation goes hand in hand. And then there's re-implementation research. And re-implementation is another field in which you're having to think about why something didn't become sustainable within that particular environment. Maybe was the implementation strategy wrong, or was this aspect of it, the uptake, whatever affected the uptake, or many other factors. So, how do you re-implement that in that same environment using probably a different modality to see that it's sustainable? So these are sort of the three general buckets of implementation research from my perspective. We all are familiar with the eight Proctor outcomes: acceptability, adoption, appropriateness, cost, feasibility, fidelity, penetration, and sustainability, which were described in the seminal paper that was published in 2011. And in fact, other seminal work in 2000 showed that when we think about implementation research, we know that a lot of these evidence-based strategies are not getting implemented. Westfall's uh, publication in 2007 basically showed that it takes at least 17 years for less than a quarter of these new discoveries, 17 years for less than a quarter of these discoveries to enter day-to-day clinical practice. So we know that people are not receiving the most up-to-date evidence-based care, whether in the US or other global settings. So how do we really shrink that 17-year time gap? And that's what implementation research is here for. For research, from my perspective, is very complex. We don't control the real world. We try to make sure that we make sure that we incorporate the complexities of the real world in implementation research. Some say that this is sort of like a very interesting cube, as indicated by this illustration. We know that it's multifaceted, it's multi-layered. We know that we have to engage stakeholders. And also, we know that population level impact is very, very important in terms of implementation research. But those are surrounded by the core concepts of that we have to have evidence-based interventions, and I'll talk a little bit about what that evidence should look like and how we really make that evidence stick. We have to make sure that we are aware of the context and the adaptation, and then we have to understand how we do this in a real world setting, right? So, talking about the importance of evidence and how we are measuring outcomes. So, when we think about evidence in implementation, we have to look at the evidence pyramid, right? This is the evidence-based pyramid. And this has several things, right? There is a layer which shows that it goes from more unfiltered to more filtered evidence, right? Within the evidence-based pyramid, the sort of foundation of that pyramid is the less rigorous background information and expert opinion. As we move to unfiltered, we have case studies. These are more rigorous, cohort studies, and by far the most unfiltered is the randomized control trials. For any sort of condition, you can think there can be 5, 10, 15, 20 randomized control trials. How do you judge all of that evidence, right? How do you really quantify that evidence in a way that can help you think about how you're going to implement it? Well, you do what is called rigorous systematic reviews and meta-analysis. This is the filtered information in which you set priorities, you ask a specific question, and you look at the research design so that you can weigh the evidence and say, yes, this evidence is really true in terms of is strong in terms of implementation, or this clinical evidence needs some more in terms of we need to do some more work to really bolster that evidence base, right? Within my IC lab, we are in the implementation space. We sit at what we call the translational phase 4 research space, which is late stage T4 dissemination and implementation research. If we think about research as a sort of a continuum, we start here from basic discoveries, go to translation or T1 in humans, translation to patients, and translations to practice, T2 and T3. Once we have done all of this, then how do we really have wider population level impact? And that is where dissemination and implementation research comes from. So within our lab, we focus on problem recognition. Where is the evidence existing? Assessing the existing evidence and implementation gaps in healthcare delivery. Remember, we're not generating new evidence. We're assessing the evidence to see where there are implementation gaps. And where it is appropriate, implement actionable evidence-based interventions through established implementation strategies so that we can test the adoption of these evidence within real-world settings. Our strategic framework for our lab follows sort of this general way of thinking. So evidence synthesis, as we said, is basically focused on our lab utilizing implementation-focused systematic scoping and umbrella reviews to really synthesize the empirical evidence that exists. Now, the evidence as shown in the evidence pyramid can come from cohort studies, can come from randomized clinical trials, can come from case studies, can come from qualitative studies. How do you really merge all those studies in a way that makes it rigorous so you can understand the evidence, the breadth of evidence, so that you can implement it? Now, sometimes when you synthesize the evidence, you see that there's a hole in that area and you need to actually do more evidence generation. In this case, we can generate empirical evidence through biomedical behavior research, right? So we can do sort of epidemiological studies. But in other cases, if the evidence is robust enough, we can skip past the evidence generation and go to evidence-based implementation, scalability, and sustainability. So the evidence is robust enough, and we know that how we can implement this. So this is where we go in the green arrow. Several of our projects in our IC lab fall within the various domains as we've stated: evidence synthesis, evidence generation, and then, of course, evidence implementation. And you can see some overlap. Overall, the evidence synthesis really underpins both our evidence generation strategy and our implementation strategy in many ways. So we have to look at that literature. For example, we have really looked at randomized control trials in terms of what we look at for sickle cell disease in this case, looking at evidence synthesis. We have synthesized the evidence around randomized control trials, right, in terms of the use of interventions. We also have synthesized the evidence around hydroxyurea, looking at the cost and the adoption and the acceptability, which informed our ongoing clinical trial in Nigeria here called Accelerate. And in fact, we've also done many qualitative evidence synthesis, right? You can do quantitative evidence systematic reviews and qualitative synthesis, looking at task sharing as an intervention for mental health for sickle cell disease here with our recent publications. And then finally, in many ways, we've looked at both not only global evidence, but local evidence. Not only do we do work globally, we also do work locally. So we're looking at sickle cell disease outcomes for US populations to start synthesizing that evidence using existing data sets, including the National Health Interview Surveys, right? That is a national data set that we've been able to glean some data in terms of sickle cell disease outcomes for the United States. And then we've also looked at state level data, specifically for New York State, where of course I'm at NYU. So when we think about sickle cell disease, we think about New York State because at least 10% of the individuals living with sickle cell disease in the United States reside in New York State. So anything that we do globally has significant local applications and in terms of the work that we do. So our data, specifically on the temporal differences in sickle cell disease hospitalizations, which is informing our strategies moving forward, has been published. I believe this was published in JAMA Open Network in May 1 or so, led by my former doctoral student, who's now Dr. Alebu, who just graduated. Um, so globally, we know that there are insights in terms of sickle cell disease, for example, at the global, national, and local levels, which makes us a call for action. The action we take is based on sort of what we can glean for systematic reviews and our evidence synthesis. So why is evidence synthesis important? So if you walk away with this, with nothing else, I want to at least impart to you that evidence synthesis implementation research is sort of foundational because it tells you what you need to do. First, there are really four reasons. It identifies what works across different contexts. So you need to understand what works in one context might not work in another context, but you can understand how the contextual adaptation can really inform your implementation strategies. Two, again, it guides the selection of your implementation strategies. If you see that something's working in a similar context, that might guide you to use that implementation strategy. Is it task sharing? Is it audit feedback? Is it consumer education or community education? Is it provider level education? Is it patient education? Or is it a combination of those various implementation strategies in terms of implementing your evidence-based intervention? It is dependent on what you're looking at, when, and where. And finally, because you generate evidence by doing a systematic review, that strengthens policy and funding decisions. You can go to people and say, we have synthesized the literature on X. We know this is why. And in terms of literature, you can also assess the cost aspect of it, right? Policy and funding decisions many times are predicated on cost. Once you synthesize that, you can look at the equity impacts of it and also the impact of various other, excuse me, various other components. And finally, the most important thing is identify gaps and future research opportunities. By synthesizing the evidence, you can identify where there's evidence lacking in one area, where the evidence is strong in one area, and also identify what particular future research opportunities, which are important in also policy and funding decisions, right? So, evidence synthesis is important because it is foundational to implementation science, because it transforms individual studies into actionable knowledge that can drive sustainable policy and practice change. It makes the evidence stick. Once you've synthesized the evidence, you can then make that evidence stick, right? So, finally, tools and strategies. So we know about low value care, right? We know that, in fact, there are a lot of articles written about what the evidence says, as opposed to what doctors say, and the evidence says no, but the doctors say yes. So for example, this intervention should not be used anymore, but doctors are still using it. And this impacts a whole host of diseases and disorders, right? And affects patients in terms of very fundamental ways, and sometimes can lead to a lot of medical mistrust, right? And we know that in the literature, because new information is coming out every single year, there are over 100,000 publications every single year. We are going to find new evidence that tells us we should not be doing what we're doing now. What we're doing now, 10 years from now, there are going to be a lot of medical reversals because that is the way science advances. So that is not the issue here. The issue here is how do we get people and clinicians, practitioners, customers, patients to use the most effective evidence, right? How do we make that evidence stick? So these are some examples of de-implementation of low-value care in terms of evidence. But if we're thinking about this, I think we need to really think about how we really synthesize the evidence. So in terms of tools, my lab has created a specific strategy of how to do systematic reviews using specifically an evidence-focused implementation research lens. So this is the website here. And when you go on my website, you can click under tools and there's something called instructional videos. Here is the purple arrow pointing you to that. So in terms of the purple arrow right there, you click on instructional videos and there are instructional videos on how to conduct high quality literature searches. High quality literature searches from an implementation research perspective, asking an implementation question, how you sort of delineate that question, and how do you arrive at your answers, right? We've done a lot of these in our lab. At last count, I think we're about now 10 systematic reviews looking at it through an implementation lens. In addition to that, there are several videos there that talks about how you set up your PICO question. that is population intervention, comparator, and outcome in terms of it, and how you set it up specifically from an implementation science framework. Again, this is how you make the evidence stick, right? Understanding what the evidence is. I just went over the evidence pyramid, so you need to really understand what you should be looking at in terms of your evidence. Also, uh, videos on how you search PubMed and other databases, abstract searching, and then two things that we use. EndNote is another thing that we use, and Confidence in terms of how we use those for our evidence synthesis. So we have all of these tools that are available that you can utilize from an implementation framework. And in fact, we'll be submitting a publication soon, sort of that delineates many of these tools that you see here. So you are actually the first group to really that I'm really discussing these tools with, and then we'll have a publication on these tools that will be coming out toward the ends of this year. So, final thought. Final thought is this. You can generate the evidence, right? And you can have a whole host of publications. However, you need to do engagement and outreach. Last year we had a 2025 sickle cell disease symposium in terms of some of the work that we're doing in New York City. These are our four panelists in terms of eminent scholars and individuals with lived experience for sickle cell disease, and they talked about sickle cell disease and some of the issues that are facing New York City and New York State and how we can address those. So, when you have the evidence, you need to gather people, like-minded people around so that you can start to impact some of this evidence. Now, our symposium proceedings have been just published recently in Frontiers in Health Services Research. And in addition to that, we're actually working with the at Akunle Gold Foundation, and some of their work at Akunle Gold has been one of the main advocates in his foundation about sickle cell disease. Specifically, he struggles with it, and he's been interested in some of the work that we're doing in Nigeria and also in New York City. So this is something that we did last year. So again, when you have the evidence, you have to reach out to stakeholders to get them involved and understand that evidence. So this is our lab in terms of a lot of the stuff that we do. Here are some of our pictures in terms of colleagues and some of our visits. So indeed, I am happy to answer questions in terms of everything. So thank you so much. Thank the organizers. And yeah, thank you.
Thank you so much, Professor Emmanuel Pepper, for that deep dive. It was quite the deep dive into the work you do. It was quite insightful to see the build up from lemon treating scurvy to the work you do with sickle cell disease and all the way to the tools, which I'm wondering, by the way, if it's free.
Yes,
But then I have
all
a
of the
couple of,
tools
it
are
is
free.
free.
Yes.
Great. So I have a couple of questions for you. So you
Mhm.
have walked across the NIH leadership and global health implementation. So from your perspective, I know there can be a plethora of reasons, but what is that single biggest reason that evidence-based interventions fail to become sustainable policy or even routine practice in the real world health system?
That is a great question. And the answer to that is that too often interventions are designed as short-term research projects rather than solutions that can be realistically adopted, financed, and owned and maintained by local health systems. So the truth of the matter is, when we're doing evidence-based interventions, we have limited funding. It doesn't matter what academic researcher you are, there is limited funding. Sustainability requires alignment with several things, right? Workforce capacity, financing structure, policy priorities, right? So this has to be a policy priority of the government, local leadership buy-in, and community trust. All those aspects are outside of the domain of the researcher or the research team. So it's important that we understand that if we are going to have evidence and these interventions stick, we have to make sure that we don't design it as a short-term research project, which we are limited given the funding structure that we have, to something that is really embedded within the system. So that takes a lot of forethought to really think about how you embed that within the system. Thank you.
So what I'm hearing is, although there are a couple of overlapping components that
Mhm.
hinders the evidence sticking, the biggest one from what you're saying is them designing them short term. The interventions are short term and not long term. And of course, for them to be designed short term, we know that there is a lot of reasons for that. It could be funding, it could be a pull-out from the donors, it could be just about anything, but then we need to design for more sustainable impact. Okay.
Right,
Thank you
exactly.
for that. Yes. So given your work on translational research and implementation science, so how do you see contextual heterogeneity, sort of like comorbidity patterns in people living with HIV, mental health, cardiovascular risk? How do you see this shaping whether an intervention is either scalable or not across LMICs?
Well, I would have to say that contextual heterogeneity is one of the most important determinants of scalability, right? As you stated. Interventions that work in one setting may not work in another setting, as you said, different populations, different disease burdens, different healthcare infrastructure, right? Workforce capacity. Again, stigma against associated with some of these other diseases. So scalability really depends on designing interventions that are acceptable rather than rigid, right? We have to make sure that we really work with the local communities, and we think that at least from the work that we've done previously here and also in the US and in Nigeria, that implementation science can really help identify some of the core intervention components that must be constant, right? So there's some things that are immutable that cannot be changed. If those things are there, everything else should be able to be changed in terms of so that you can address the contextual heterogeneity within any sort of population for any disease outcome that you're looking at, right? That is I think one of the key advantages in terms of implementation.
Thank you so much for that response. So I'll try to move this along because of our second speaker, so we don't spend so much time in one place.
Not a problem.
So yes, from your experience managing large NIH portfolio, what metrics or accountability frameworks best ensure that implementation research does not stop at just publication, but translate into measurable health system change? We want to know, it's very easy to synthesize the evidence, to publish the evidence, but how then do we translate this into measurable health system changes?
So, as I pointed out, that's why I put in the slide about the 2025 Sickle Cell Disease Symposium we had at NYU. So, in that symposium, we invited people from the City Department of, what is it called? The City Department of, I want to say, Health and Hygiene. I'm sorry, I'm not getting the name correct. But we invited various stakeholders, community advocacy groups, all of these people who have an interest in sickle cell disease within New York State to sit around the table. So if we want to talk about frameworks that ensure does not stop at publications, you need to go that extra step and get that community engagement piece right in terms of getting people around. I'm not saying that you have to have a symposium like we did. We found that a symposium was very helpful in building partnerships and making sure that we are at least start talking to many of the main and key players within the state and making sure that we are moving are starting to move an agenda forward. But getting people around the table helps identify priorities, align on strategies, and move things forward. So that is the hard work, is that stakeholder engagement piece. We have a 2026 symposium coming up in September, and it looks like we're going to probably be doing a lot of this engagement on an annual basis and keeping in contact with many of these organizations that have various interests in sickle cell disease in New York State.
All right, thank you. So what I hear is, instead of just synthesizing your evidence and publishing and then shelving it, you need to talk and talk and talk about what you do in the places that matter. Bring up
Correct.
the
Correct.
discussions and enough stakeholder engagements, ensure policymakers are hearing and listening to you. That's basically how we translate it into the change that we want to see. Thank you. So one final question before we move to our second panelist. If you were advising ministries of health and funders in Africa today, let's assume you're one of our big advisors. So what two actionable strategies would you prioritize to ensure that this evidence sticks beyond the pilot stage and become properly institutionalized?
So
Two
that's a great
strategies.
So that's a great question. Number one, first, I would prioritize embedding implementation research directly within national health systems and policies rather than operating them as parallel research programs, right? In the UK, they have something called the NICE, and they have a lot of some of these embedded elements. Second, just to be brief, I would invest heavily in local workforce development and implementation capacity, right? Including community health workers. We know that community health workers can deliver a whole host of interventions when we can do task sharing, invest in implementation research, because if you're going to embed this in the system so you know what's working and deeply scale it up, you have to have scientists. And then you have to, of course, have data systems to collect these. So again, institutionalization must occur when countries build local ownership, financing mechanism, and implementation capacity. So it is that institutionalization that's very, very important to really understand how we can adopt these evidence and then scale it up on a national level.
Great, thank you so much, Prof. Although I do have some follow-up questions, but we'll give room for our second speaker. We would have maybe another session later where we could bring up other questions. So our second speaker, Dr. Ogunshola. Oh, Prof has a question. He has his hand raised.
Is that a question for me?
No, Dr. Pepper, I just wanted to say thank you so much. And we're all very grateful for all the work you do, but in the US, in Africa, and in Nigeria especially. So we are very grateful for that. I think training the workforce that Africa needs is a job of every African, no matter where they are. So I always tell somebody the least we can do is exchange ourselves, train somebody else in the continent for the continent that gave you up halfway to go to US and everywhere where we are. So thank you so much for that capacity and actually taking these platforms not just to align people to where they need to learn more information from the work you do. But also, one of the things we always ask everyone that come to speak here is for people to know the availability that you have. So I'm asking that in front of everybody and your willingness. You have done that and I've known that. But I want people to understand that when they say, oh, the problem with Africa is we don't have enough mentors. I'm saying, oh, no, the problem with Africa is that we don't have enough good mentees. And because the reason I say that is because there are people like you who are available to be able to mentor that. And I just wanted you to say it in their presence that you are open and willing to mentor people, which you have done. But I just want people to say when they come to me and say, oh, I have a problem, it's about mentoring. I say, no, if you're having problem about mentoring, it's because you're not a good mentee. If you actually know what your job is, that there have been exposure of so many people who are willing, like you, to give back in so many different ways. And all they're just waiting for is somebody who have a fire in their belly. So I just want you to talk a little bit about your availability, your willingness to mentor the African region, please.
Sure, happy to discuss that. So I have graduated three PhDs from, three doctoral students, one PhD and two doctoral of public health. I have to say that within our lab, two Nigerians have been received their doctoral degrees under me, so I'm more than happy and elated about that. And we have also mentored over 60 MPH students within our lab at the last count. So I am always available in terms of providing expertise, my expertise in terms of mentorship and in terms of the African continent. We have a D43 on implementation science and hemoglobinopathies that we are doing some mentoring aspects through. So in many ways, it requires people to reach out, number one. And number two, just because you don't hear things from other individuals when you reach out. So for me, I have to be honest, I have a lot of emails sometimes, and it takes me a little bit longer to get through all of my emails. But if you don't hear anything from me, that doesn't mean you stop. It just means you need to send me a little bit more email. So I always apologize to my students in terms of it. But I think that, as you said it, mentoring is important. Mentoring is an essential element because I tell everybody I'm going to turn 50 this year. I have 15 more years until I retire. So I need people to really sort of rise in terms of, getting PhDs and PhDs. And my students look at me like I am joking. I'm like, I'm retiring at 65. I'm not doing this anymore. I will do this on a lot less speed in terms of what I'm doing now. But I think it's always been a privilege having being born in Ghana, raised in Ghana, and coming to the United States and having benefited from great mentors. I try to be the best mentor and meet my students where they are at and mentees where they're at and try and give them a little bit of the wisdom that I've learned. So overall, I think that in many ways, you have to be dedicated in terms of the mentorship, and as a mentee you have to not give up because there are people that are willing to mentor you, and there are, if I cannot do it, I can figure out somebody that can. So I can definitely and I think within all of our networks we know of people who can provide great mentorship because again, my domain of expertise is limited. You might be working on, something like cancer, which I have no idea about. So I would probably not, I could mentor you from a more career perspective, but from a cancer specifically sort of workforce perspective, I would not be the best individual. The other thing I would have to say is that it's important to have multiple mentors, right? You just don't need one mentor, you need several mentors, right? So you need a mentor that is grounded in your domain in terms of your intellectual work. You need a mentor that has a more broader view and it has nothing probably to do with your intellectual work. So they have no conflicts, right? And they can tell you specifically and speak with you freely. Sometimes people that are in your same field of area have some conflicts and they might not provide all of the advice that you need, but it's always good. And then also you need to think about mentors through your career stage, right? The mentoring that you need when you start your career is not the same mentoring you need at the mid-career level, and it's not the same mentoring that you need at the late stage career mentor. We all need mentors, period. It doesn't matter if you're 50 years old. I still have mentors here. Dr. Olga Degby at the School of Medicine is a great mentor of mine, who I've known for several years, and other individuals too. So I'm 50 years old and I still have mentors. So there is, I will say this, there is not a time in your life that you will not need a mentor because you always need some wise advice and you need people who have a different perspective than you when you're dealing with many interesting issues that come up in terms of your career. So.
Thank you so much. I just felt like it would be an opportunity. It's not all the time that a lot of people that are here are seeing you. So thank you so much for providing that perspective. Over to you, Dr. Ahmed. Thank you.
Thank you so much, professors, both of you. Thank you for that delivery. So we'll be moving on to our second speaker, that's Dr. Olabanjo. If you could just unveil yourself so we could have this conversation.
Yeah, thank you, the moderator. But I will try to leave it on, but it seems my network is not perfect today, so I may need to off the video as we go. Thank you.
Okay, to save bandwidth, that's fine. That's fine. So as long as we can hear you, at least we've seen you now. We have a face to the name. All right. So the organization that you work as a principal, APIN, Public Initiative, has been at the very forefront of large-scale HIV program in Nigeria. And from your experience, what has been the most effective way APIN has ensured that research evidence is actually embedded into service delivery systems? And this is not just HIV. I mean, every other experience
thank
that
you
you
so
may
much
have.
for this opportunity to speak.
Okay.
Hello, can you hear me, please?
Yes, please go ahead.
Can you hear me?
Yes, Dr. Olabanjo, we can hear you.
Hello?
Dr. Olabanjo, we can hear you.
Okay, you can hear me. Yeah, so thank you so much for that
Yes.
question. Yeah, so APIN Public Health Initiative integrates research directly into program implementation, rather than treating research and service delivery as separate entities. And this is not come at the beginning, but as we evolve over many years, we now realize that what we are doing is implementation, but there are evidence that need to come in to improve the quality of our implementation. I'll give a good example. I'm sure most of us on this call may be aware of this publication, the baby shower publication that was done in Nigeria, an NIH-funded grant that was done by Professor Echi. The baby shower was to improve maternal and child health, really. And it was done within the Christian setting. And we felt that this was a good thing, but the context, we wanted to move further from the Christian setting to the Muslim setting. So we have to look at the context and we have to do some adaptation. And really, that has helped to improve service delivery to Muslim women, to improve maternal and child health. Currently, we have a publication that is undergoing review on that at the British Medical Journal of Global Health. Apart from that, the use of electronic medical record, health information system to drive evidence-based decision-making and continuous quality improvement has helped us to embed research evidence into service delivery. So we are seeing data. We are seeing what the program is saying and the way we should go. The other area is that we cannot do this on our own. If you're talking about implementation research, implementation science, we have to look at the stakeholders because we are just a part of a system. We are supporting the government. So we need to involve the government, the Ministry of Health. We need to involve NACA in our setting. We need to involve the Nigerian Center for Disease Control. And this involvement is important at the beginning because we need to align our research, our service delivery to national priorities, and that will allow it to inform policy change if it's needed. So working with these critical stakeholders and the community itself. So I was giving an example of how we adapted the baby shower into the Muslim community. That involves meeting FORWAN is the Federation of Muslim Women Association of Nigeria, meeting NAFSAT, meeting the Association of Imams to see how can we take this context that has worked very well, this intervention that has worked very well in the Catholic setting into the Muslim community. So those kind of interactions really brought out ideas in which we now look at the context and did some adaptation to improve maternal and child health services.
All right, thank you, sir, for your response. What I gather from what you have said is contextualization is very important. Whichever context you find yourself, you need to be able to understand their nuances so you can tailor or adapt your implementation to their own context. And then the EMR as well, that is able to drive evidence-based decision making, and then also engaging stakeholders, all necessary stakeholders from the onset. This would help you at least with buy-ins and being able to enter certain communities, and that way you're able to bridge that gap between programmatic data and also help service delivery. That's what I hear. Thank you. So next question is, what tools or operational strategies? Sustainability is often a major challenge everywhere. Once donor funding ends, sustainability is a problem. So what practical model has APIN used or is exploring to ensure that there's continued accountability and performance tracking after this external funding cycle? Dr.
Thank you so
did
much
you
for
hear
that very brilliant.
Okay.
Yeah, thank you very much for that brilliant question. In implementation science, we talk about one of the outcomes is sustainability. And one key way to do this is to we are working within a system, and the system that will drive policy change that will maintain service delivery is actually the government system. So carrying the government system along from beginning of our implementation, letting them see what we are doing, our strategies, and also asking the question, does this align with the national priorities? Because one of the things is that sometimes, because we are funded by donors too have their priorities. And sometimes the priorities of donors does not align with the national priority. And that's the truth. So that sometimes you don't just take the money. It's good to have the money, but how will this align with the national priority? Once you are able to solve that problem, it's easier for government to own the program, and it will support sustainability. Apart from that too, we are also building capacity of the workforce, in the government workforce. Because we are donor driven, we have some exposures because of the kind of work we work with the US system a lot. So what we are doing also, can we also train the government workers at the local government, the medical officers of health, the nurses at the local government, at the state ministry of health, even at the federal ministry of health? Can we build their capacity to drive program, to drive implementation? The way we use data for decision making, can we also train them to do that? And one thing we've done is that we've also installed performance dashboard in the offices of the commissioners of health and the director of public health in the states that we are supporting, because that will also help them to see in their office, what is the data saying? What is the program saying? Where are we doing well? Where are the gaps? So in essence, one, involving them from the beginning, building their capacity, and also giving them that ability to see the program data, real-time program data, so that will guide them in making informed decisions.
All right, thank you, sir. Earlier in the conversation, when Professor Emmanuel was speaking, he was meant to act as an advisor to our Ministry of Health. He was saying something about investing in the health system, embedding all of the structures in the health system. And I was how do you do this beyond donor funding? So I'm glad that the conversation came up now, and Dr. Olabanjo was able to shed some light, letting us know that, the government systems are the ones that are meant to be held accountable, especially with the dashboard that you have even put in their spaces. It's in their faces, and they know that if things aren't working well, it's not like they are not aware. And also capacity building at every level, state government level, local government level. So we're ensuring that sustainability is long lasting beyond the donor funding cycle. Thank you very much for that response. So next question is, what would you say is the most common mistake stakeholders make when trying to scale interventions from research settings into national programs, and how can these be avoided?
Yeah, thank you for that very good question. Let me say, one thing we should know, that most researches, if they are not implementation science researches, are done in a controlled system. That means not in the real world system. So you have everything. And if stakeholders pick such kind of research and move them into the real world, that's usually a problem. So the best thing, one of the mistakes is that sometimes they want to scale up intervention that perform well in controlled research setting without adapting them to the real world setting, which is what implementation science is doing. Implementation science bridges the gap between know and do, the know-do gap. So that what are the factors? Let me give an example in Nigeria. So let's look at a common thing, maybe issues about maternal and child health services. We have to look at the operational constraints, workforce shortages, look at the supply chain, look at the infrastructure limitation, inconsistent data systems, and varying state level capacity. But if we don't look at this constraint, in a research setting, if it's not implementation science research, because of the resources there, you incentivize the workforce, you provide almost everything they need, then things will happen as if it's good. But in the real world, whereby you come to implement and see how will this operate in the real world setting, then it will show the gap. So one of the mistakes is just picking up things. Then we also need to look at issues about context and adaptation. That something works well, even if it's implementation science, that works well in South Africa does not necessarily mean that you bring it the way it is in South Africa and bring it to Nigeria and you think it will just work perfectly the same thing. I give you an example of what was done in Nigeria, the baby shower research. It was done in Nigeria, excellent research, funded by NIH, well publicized. But it was done in the Catholic setting. So just taking it, we realize that we need to do some adaptation, even within Nigeria. So one of the major mistakes is just picking things and running with them. Then a major thing too, because in Nigeria, Nigeria is big. And sometimes government wants to be government to say that we need to implement everywhere. But sometimes it may be better to start in phases so that you learn as you go on, phase intervention, especially if it's a new thing, so that you monitor, you have your system inbuilt, you learn from it, you adapt, you change things until you are fine, then you can scale up. So one way to avoid this is that at the beginning of any intervention, we should think about sustainability, which is a major implementation outcome. We should also think about scalability. Then we should look at cost, because most things will be donor funded. But when the donor goes, can the government maintain this? Then what of the workforce requirements? Because if you are doing some research, even if it's implementation science, sometimes there may be some benefit, even if it's not monetary to the people involved. That could be an incentive. If that goes off, will the people continue to do the work the way it was done when it was at that stage? So those are the things we need to think about. So we need to look at those issues. And I would say that we need to embed implementation science research into our routine service delivery. And that even at the ministry level, both federal, states, that should be core as they do things. How can they implement this in the real world? When we do this, we'll learn faster and we'll grow faster.
Thank you, sir. So my take home from this is there's no one size fit all. If you're going to scale from maybe your pilot was in northern Nigeria or southern Nigeria, and intend to scale, there's no one size fit all. You have to adapt to the new context. Another thing I heard is you take your implementation in stages so that you can learn, you can adapt, and you can build before you take to a different setting, or you're able to scale up from where you started. And we're also meant to health system delivery, you're supposed to be able to translate research fully into the health system delivery. So that's my take home, and I'm hoping that our audience too have taken a thing or two away from this conversation. So thank you both for all of the conversations so far. And we have spoken about everything from generating evidence to that can inform policy and evidence that sticks. Also translating research to service delivery, and we've talked about sustainability and how we should plan for sustainability from the very beginning of our initiation stages. Now, I have one question which is to be directed to both of you. So we've talked about sustainability, but then there's a trend that I have noticed, especially in our implementation research in Nigeria. When documenting impact of certain projects, we tend to lean more towards success stories, anecdotal evidence. But then when it comes to using indicators that actually help us in showcasing the true impact of the project, a lot of projects are found wanting. So how do you think that some projects, or maybe how do you think some projects would be able to adapt, or more like plan for their project, such that in the end, they're able to show evidence, true measurable outcomes of their projects at the very end, and not just rely on anecdotal evidence? Over to you. Okay, Prof, go ahead, please.
Sure. I think it's important to collect rigorous data. You have to plan the data collection phase of every project. Anecdotal evidence is just that, anecdotal. You can't publish anecdotal evidence, so that's, but you can publish rigorously collected data. I think it's the construct, how you construct the study from day one to make sure you're collecting all of the important evidence, make sure you reached out to stakeholders, understand what evidence they will need to make their decisions. Again, any well-designed, excuse me, any well-designed project really needs to focus on rigorous data collection and validation of that data so that at the end of the day, if you don't have that, unfortunately, all you have is anecdotal evidence. So thank you.
Thank you, Professor Emmanuel. Dr. Olabanjo, would you like to chip in?
I totally agree with Prof. Emmanuel, and I just want to say that the design from the beginning, from the beginning, we should think about dissemination, because for any project, and which is also a science, that's what we call dissemination science. What message will you pass across to the stakeholders, which may be government, the community itself, where you work, external stakeholders? So, and this should start from saying, what are my aims? What are my objectives? What are my metrics to measure success? So once that is defined, then it will be easier to know what to know and say how successful your project is.
Okay, thank you. So I hear that we need to plan rigorously for data collection, meaning we need to have a very thoroughly developed design from the maybe proposal stages all the way to getting IRB approvals, all the way to going into the field to collect the data. It has to be rigorous. So that we would have something publishable by the time we're done with analysis. I mean, that's a recap. So thank you for all of your insightful contributions. Our panelists have had very, very rich and insightful contributions so far, and our audience, we thank you for your thoughtful engagement. Although we haven't seen that many questions, we're still hoping for many questions for our panelists because they're a wealth of knowledge, and we hope to tap into as much of it as possible within this very short time that we have their attention. So a clear theme from today's discussion is that making evidence stick tend to require more than just generating data. It demands intentional systems for accountability, continuous learning, and alignment between researchers, implementers, and policymakers. Everybody has to be in the know for our evidence to stick. Now, as we conclude the session and this week, I hope we leave with a renewed commitment, not only to produce evidence, but also to actively design for its uptake, sustainability, and measurable impact within our health systems. So please, if you have questions for our panelists, we're hoping to see many more questions from you in the chat so that they can respond to them within this time. I mean, you may not have this opportunity to speak with them in the nearest future again, so we're hoping that you're able to reach out immediately. Yes, Professor Eche.
Well, so I do have my own learning and my own questions that I hope that the people that are on there, it may be a little different from what people want to ask, and that's why they want to ask their own questions in the Q&A, but I'll ask mine. And, one of the things, Pepper, that people ask me that I struggle with the answers. There was this team, they were talking about who needs training in implementation science, and what training do they need from implementation science, and to what purpose is this training for? And for me, I have given an answers in terms of thinking it depends on where you are, because the training that you need depends on the workforce needs of the place that you are also situated. For example, you could need a training that is based on a programmatic thing. I am running the leprosy program in Nigeria, and I need help on how to design intervention to reduce the stigma associated with leprosy. and I go to somebody that is at Harvard and say, that is what I wanted to learn. And like you said, that person have never seen leprosy. That person has never been able to do, but he can mentor you on how to select implementation strategies, how to think through implementation strategy. He may not be able to tell you anything on leprosy per se, but these are what I call transferable skills. So what I wanted to hear from you is to really talk globally about when people seek training and when they seek capacity building, how should they seek that to benefit, if not so that it doesn't just become we have more alphabet to our name. You have an MD or PhD, then you add more alphabet, an MPH, and you have more alphabet, a DLPH or an MD. So, but instead of that, to people to say, I'm here where I am. I'm working in the program. I'm running the immunization program. I'm running the TB program. I'm running the leprosy program. I'm running the onchocerciasis program. But I think implementation science can help me. So generally, how do you think people should approach seeking for training and capacity building in implementation science? Thank you.
So, training is a journey, number one, and I think you're absolutely right. It depends on what stage you are at in terms of program management for implementation, and then also what questions you're asking. I think the one thing we have to understand that implementation science is defined as team science. 100%. So there is no one person that's going to have all of the answers when you're doing implementation work. That is impossible. You can bring, your own level of expertise to it in terms of the disease question. You need a person who's trained in implementation science to add the core components to it. And then you need other individuals, even community health workers, etc. So to me, what I have seen is the fallacy in terms of when people think they have done a course in implementation science, they are knowledgeable to carry on. Whereas it is more of a journey and you learn more things. I learn more things from reading the literature, things that I don't know of, new implementation, ways to do implementation work, new modalities, and generally new things that people are doing, which really adds to my knowledge base. But at the end of the day, honestly, I don't consider myself to be an implementation science expert. I do implementation research, right? But I know that there's a lot that I also don't know, and I depend on all of those individuals to have input because that's truly how you really create uh, truly something that's sustainable and truly something that can be impactful. So I want to say that number one, we have to understand that it's a team science. No one person has the answer to everything, but everybody can build, uh, can use their experience to help sort of implement and design that trial. Number two, I do agree with you. Implementation, understanding is based on where you are. I think fundamentally everybody needs to understand the fundamentals of implementation. And the deeper dive you go into it, that in terms of, expertise, etc., the better you are at it. But overall, it really requires a whole host of learning, and then it requires a team science approach and as you stated, and also importance in terms of understanding what you're going to be doing within that research project and making sure that you have notable experts and other individuals who can provide uh, implementation science expertise. You have the domain expertise and other individuals. So again, team science approach. So I hope that's helpful.
No, this is very helpful, and I'm hoping I'm taking your time to give people time to ask their questions. Again, if nobody is asking, I'll use your time to ask my own question for my own learning. But this is your chance to be able to ask those questions. Because when you talk about team science, I remember one of the things I met with an oncologist, and the way you asked, and he's saying, I really want you to teach me. I want to become an implementation scientist. I say, you don't need to be an implementation scientist. You need to be a good damn oncologist. Because when you're a good damn oncologist, then you can bring me to your grant or to bring anybody else that does implementation science and say, can you help with this implementation science? You know, it's so funny when I've seen people like, you see somebody who is everybody, instead of actually focusing on being very good with their, they're all just trying to, oh, I'm an implementation scientist, I'm a cardiologist. Well, you know, pay attention to the cardiology and do it very well, understanding that there is, these research groups are a team science, like you said, but the challenge in that team is that you have to bring something to the table. But if you're now coming to that table, you're not bringing your special area, which is oncology or cardiology or nephrology or whatever that specialty, your content area special that nobody else in the team has, that you do. For example, I'm a pediatrician. And if you're doing something, I'm not going to be the oncologist. I'm not an oncologist. I'm not so, but I need that oncologist to be on the team and be very good oncologist by that way. Then you can bring yourself. But when people try to do that, and that's what I want people to understand, I went to do an MPH and I did my MPH not so that I can become a biostatistician. I am far away from a good biostatistician, but I know the language to tell my live biostatistician what I need. So when I'm talking about the biostatistician, say, okay, so what is your PICO? I know what PICO means. I know my population, my intervention, my control, my outcome. So I can use that to speak with the statistician to say, this is what I'm. When he talks about binary numbers, you know, and then so it is for me to understand the language. That was what my MPH was. And you might say, why would somebody spend that amount of time to get an MPH? It wasn't to become a biostatistician. So if I'm writing a grant or doing a project and that I need a real statistician, I am not going to assume that because I have an MPH, I've suddenly become a biostatistician. I'm going to find the best biostatistician on the table. So that's one of the things I want people to understand is to build your career in a content area where you are very well, and then be able to learn enough implementation scientists to know that you need one, and then bring that one to be to the table and strengthen your team as a team science. I think I've taken enough time for people to ask questions, so I will stop again and see if any of them did. Thank you.
Thank you, Prof. So far, our audience are very, very content with everything Prof and Dr. Olabanjo has said. They don't have questions.
There are questions in the Q&A. So
Oh,
you might take a
there
look
are?
at it.
Okay. Oh. Sina.
Yes, there are 2 questions.
Okay.
Oh, 3 questions now.
Okay, I don't see that from my end.
Oh, okay,
please
okay. Then
go
I'll
ahead.
read it out. I'll read out the first question. The first question is from Professor Mpo, and he's saying, my very limited understanding of implementation science is that it is concerned with translating established evidence into policy and practice and sustain the practices beyond the project lifetime, but does not include evidence generation and evidence synthesis, which are core domains of basic and clinical researchers. Please, can you clarify this for me? So, Prof. Emmanuel?
Yes, I'm happy to take that on. So we say evidence-based intervention. So established evidence requires, I would say that evidence changes based on what we know. What we're doing 20 years ago is not the same thing we're doing now, right? We know that the medical evidence has changed in a whole host of fields, and there are tons of publications. So there is that evidence that's always evolving in the scientific arena. So when we're thinking about that, what I'm proposing is that for implementation research, you have to understand the scope of the evidence, right? In terms of evidence synthesis before you can do anything. So in the 4 points that I said, you have to understand where the gaps are. You have to understand what has been done. As Professor Olabanjo has stated in his example, there are, an evidence-based intervention that worked in South Africa. Just because it worked in South Africa does not mean it can work in Nigeria. However, you can do an evidence synthesis to look at that intervention, look at how it has been implemented in other African countries or either non-African countries, right? In other settings, see what they did because that can inform the specific delivery that you utilize in Nigeria. Again, that is the evidence synthesis aspect that allows you to identify the gaps and where you want to fill the gaps. So from my perspective, I'm not taking on implementation work unless I have done an evidence synthesis. So I would say this, I disagree that evidence synthesis is the core domains of basic and clinical researchers. I think evidence synthesis is a scientific expertise that is utilized across the board. So I would say that in terms of evidence synthesis, it's very important for our work that we do in implementation research to understand what is the available evidence around and really tell us what we shouldn't do. It should tell us what we can do, what we shouldn't do, or where there isn't data enough for us to do X, Y, or Z. So to me, that is an important element in terms of implementation research. If you do
Okay,
evidence synthesis through
and then the next question, which is related, is someone is asking, what's the difference between implementation science and health policy and systems research?
So implementation science can inform health policy. Systems research can take a whole variety of sort of domains. There's implementation science in a system, right? That can be quantified or qualified as systems research if you're doing a systems level intervention among several systems to see how you embed. Again, similar to the conversation of how you embed something within a system, you have to look at it from a systems research perspective, if that is your implementation question. Your implementation question can be capsulated in very areas. How do we do something within one clinic? How we do something in 5 clinics? How we do something in one hospital? How we do something in 10 hospitals? How we do something nationally? How you do something in 5 clinics as opposed to 5 hospitals is different because the workflow in clinics are different because of their capacity compared to the workflows of hospitals. And then when you're thinking about how you do something on a national level, again, it can be the same set of interventions, but how you implement it nationally is a different question. So again, it depends on the question that you're asking in terms, and unfortunately, the answer can be slightly different depending on what level you're working on.
Great. Thank you. Okay, over to you, Haishat.
All right, thank you, Prof. Tonya, and thank you for the responses, Professor Emmanuel. They have been really insightful. I know I'm learning a thing or two, and I'm pretty sure that those that asked the questions have gotten responses that are that have, well, quenched their thirst for that knowledge. Thank you so much for that. So, Prof, is there any other question?
No, no other questions in the chat for now, right? Yes.
Okay, okay. And I do not know if Professor Eche wants to still fill the time a bit with some of his questions. If that's a yes, I would open the floor for that. If that's a no, then we could wrap up.
So just one last question from me, and then you can stop hearing from me for a second. So and this is to Dr. Olabanja. I don't know if you're still here. Dr. Olabanja, are you still here? Can you hear me? Can you hear me, Dr. Olabanja?
Dr. Olabanja, are you still here?
So I'm not sure if he's still here.
He's muted. He's muted.
He did mention he was having network issues.
Hello, Prof. Can you hear me?
Yes, I can hear you now. So this is one thing. So this is one thing that I want to ask you these questions. We did an experiment last year, and I want to show you. So one of the things we did, we actually in our research institute, we hired 5 postdocs from different universities in Nigeria and different training background. And what we wanted to do was to really be able to see the skill set that they have and then the skill sets that are missing. So we hired them for a period of 1 year, and we actually listed the list of the things we are looking for somebody who have completed his PhD or his or her PhD. One of those things is what Dr. Pepper was talking about. We wanted to make sure, A, that the person can do evidence synthesis. They can do a DEX review, a scoping review, a systematic review. When you have somebody at that capacity with a PhD, we expected that. The second thing that we wanted, that they can at least draft a manuscript, the first draft that goes to a research team to be able to upload that. The third thing is that they can actually do the first draft of a grant idea. So build up a little bit from the concept note and be able to put a research at the PhD level. So we hired all of those people for that 1 year to see what were the gaps. And we saw ton of lack of expertise and skills in a couple of them and a lot of them, and some of them in areas where they excelled. So we were able to identify some areas where there is strength in the training and the capacity they receive, and some areas where there are weaknesses. But one second thing we did was to move forward was to look at hires of levels in Nigeria. So the people who are in like a program. So my question to you, Dr. Olabanjo, if you running a large program in Nigeria is looking to hire someone with a postgraduate training in PhD, what skills will you be looking for that person to have? Thank you.
Yeah, thank you so much, Prof, for that brilliant question. So for us that do program, let me start by saying that generally we are more interested in skills than certificates. So I think that's my first opening statement in response to your question. So one of the skills we will be interested is skills. I'll classify this into many levels. One, in terms of working with stakeholders, would like you to have skill in stakeholders engagement, stakeholder engagement, communication skills. Then in terms of the actual work, we need to have skill in using data for decision for action. Using data for action. So you must have a kind of, you should be able to interpret data, understand data, and have skills in able to develop advocacy briefs. Because most of the stakeholders are government. Government don't have time to listen to long stories. They don't have time to listen to, they can't just give you that long time to talk. They want to see something that is very brief, but that can make them make quick decision that will attract them to say, oh, we are interested in this. But of course, we'll need some few skills in analysis, really. The truth is that if we are doing something that is so numerous, we'll contract this out to someone to do for us. They won't, overburden the staff to do that kind of. But you should have some levels of skills to analyze data, to make sense of data, and of course, you should have skill in planning generally. In planning, we have what's called the planning cycle in earth management and policy. Then we should also have skill in policy development and change. How can you influence policy development and change, policy advocacy, and things of that kind. I hope I'm able to answer you, Prof.
Yes, and thank you for that question. And the reason I asked that is there is a lot of times people tend to think it's about the degrees, and it's not about the degrees. And if I have someone who have a terminal degree, an MD, an MP, there are certain skills that you assume that goes on with there. And if people are actually taking a training program, they should not just be I'm trying to get a certificate. I know sometimes that's how it works. That's how we get promoted in our infrastructure in Nigeria. But there is something that nobody ever takes away from you is the skills you develop. Because you can move them, you can apply them to anywhere that you have. So it's important when someone is trying to undergo a training program, or whether they're going to go do a postgraduate program, or whether they're going to decide it's time for me to get to think about the skill set they need first, and then be able to say, where in what training program will I get this skill set? And hopefully by thinking that way, you are thinking about the skill set that the employers of labor will need. For example, we are looking in our office to hire someone who can help us with data management, who knows how to use RedCap. And we have been putting this ad for a long time, and we can find anyone that actually knows how to use RedCap that is willing to move around and say, let me try something somewhere and lead that group. So again, I'm using this opportunity to say, if you know how to use RedCap very well, you can set research projects on Red, you can manage, you can lead a group on RedCap, please reach out to me because there is a job waiting for you, that we need today. So the malalignment of skills. So there are many people with degrees. There are many people that say, I've done this, but said, can you manage a RedCap database? And they go back to just being able to, it's based on Excel. So if they have done Excel and be able to actually move it forward and learn more, they could do some of those things. And of course, there are so many training programs for that. But being able to match the skill set that we need to job opportunities that a country has or a region has is something like that. We all listen to the Money Point director in Nigeria, CEO in Nigeria, saying he couldn't find the workforce. Everybody descended on him and said, train somebody. But he can also add Dangote. Why the majority of people that work in Dangote refinery are Indians and not Africans. Again, he will tell you the same thing, that there is a mismatch by the degrees that we get, by the thing that to the skills that is needed in our country. There are many jobs that are open in Nigeria, but there are a few people that match those jobs. But there are places where people hold degrees and then they can find a place to match those things. So being able to step back and instead of thinking about degrees and degrees we need to get, to think about what skills do I need and what degree, of course, offers me those skills. So, but that's a different way of thinking it. Instead of saying, I want a PhD in this, I want to say, I want these skills and a PhD in this, a master's in this, or even a certificate program in this can give me. You may know that all that you need is a certificate program in implementation science. Or it may be that you need a master's level, or maybe you need a PhD level implementation science, but you need to be able to say, what skills do I need? And be able to now use that to find where you are hoping. So thank you very much. And moderator, I think I will sign off from here. But thank you so much, Dr. Pepra. And so over to you, moderator.
Thank you very much for your contributions, Prof. At this point, you might as well be a co-panelist. Thank you. So there's some other questions for both Prof and Dr. Olabanjo. Someone's asking, dear Prof, is the Covidence and other tools free for data extraction stage of reviews? How do we access them?
Unfortunately, Covidence is not free. However, there are other Covidence-like programs that are free and available that you can look and use online, including EndNote too. So there are other programs that are similar.
All right, someone else wants to know if evidence synthesis is only done by conducting systematic reviews.
Systematic reviews is one area of evidence synthesis. There's also scoping reviews. So the difference between the systematic and the scoping is systematic is you have a specific question, a specific target that you want to answer. Scoping review, you want to see a broader sort of understanding of the field. So scoping review is breadth, systematic is depth, and then there are umbrella reviews. So if there are, let's say in a field like cancer, a specific type of cancer and interventions, there are like 20 reviews. You want to do an umbrella review, which is actually a review of all these systematic reviews that have been published. So there are some areas that there are so many systematic reviews being published on a single question that it only makes sense to do an umbrella review. So those are the three areas. And then there are new areas called living reviews, which requires more updates, etc. So but the three that I would say is important in terms of implementation would be systematic, scoping, and then depending on the field and the number of systematic reviews, it might be appropriate to do an umbrella review.
Thank you for that response. I hope the questioner has gotten his answer. So this other person says, I'm not a researcher. I'm mainly interested in implementing change well. What are your thoughts on applying the learnings from the theories, models, frameworks, and implementation strategies? Also, what would you advise I share in the continuous improvement space to help with embedding and sustaining improvement?
Well, I think the theories, models, and frameworks are definitely apropos in terms of thinking about your utilization of them. Number one, implementation research developed as a field because a lot of his theories, models, and frameworks came from other fields, business, sociology, psychology, etc. So it's a hodgepodge of theories that came that were adapted for the implementation research. Because when we think about implementation research, much of it is around behavioral change. Some of it, like adoption. Why do people adopt, right? You have to think about the qualitative versus the quantitative elements of these things. So a lot of some of that work has come from consumer and business, right? In terms of how they've thought about how you can actually get people to buy stuff. Because if you buy X, that's adopting it, right? If you go, why do you need to buy this new car when you already have a car sitting at home? So that is a treatment mode. That is a sort of can be thought of as an adoption mechanism. So I think number one, as implementation grows, that's one thing I really like about this field is that we are open to new theories, ideas, and frameworks from other fields. And in fact, we have a whole host. We have a whole over 100 theories, frameworks, etc. There are several papers that have been published on these theories, frameworks, etc., and when to utilize them. So I think it's more than important and critical to understand which ones are relevant for what you're trying to do. And I think, again, it's a team science approach. So think about what are the teams you need to form if you're thinking about doing some of this work. And you do not have to be an expert in implementation to do implementation work with other people as a team-based work. So.
Okay. Thank you for that response. We have another question. Someone asked in the chat box, what are some of the resources that a person just as an implementation science can use?
So that's a great question. Let's see. So one of the things that I like to use is something called the Implementation Science Repository. Let me see if I can put this in the chat real quick. The All right, so that is one of the tools that I like to use in terms of implementation science, and as that gives you an idea of all of the tools that are available. So I am going to also put my IC Lab stuff in there, which is all the tools that I discussed in terms of, and there are actually more tools in our IC lab, which walks you through how to do systematic research, etc. So, and then of course, last but not least, I am going to put in this one. So I am putting in this, which is the Implementation Science Journal, actually. Implementation Science Journal is actually open access. So you can read the articles there. And some of these other journals that publish implementation science also are open access. So these are some of the things that can help you in terms of thinking through and giving you knowledge on implementation science. But this is sort of the tip of the iceberg. And the one thing, let's see. The one thing that I would also like that I think is a great resource here is the University of Washington Implementation Science, which I've just added right there. That is a great place in terms of talking you through an introduction to implementation science, step by step to conducting implementation research, etc. So that is also another tool. So as you look at these, there are several tools and also about implementation research. And there are free webinars that are out there that you can log in on in terms of implementation. So,
okay, Prof, they couldn't see it because it's actually dropping only for hosts and panelists.
oh,
So,
okay. So how do I
yeah.
get them to everybody then?
Okay,
I think if you click on it to say, or somebody can copy it and just you
everyone.
click on and just say everyone.
Okay.
But
Yes.
so you
Yeah,
can,
I'll move it. I'll move it. I'll move
okay,
it for everyone
okay,
now. I'll do
Okay.
that.
okay. Thank you.
Mhm.
So those are
And
just
thank you for those resources. Thank you.
not a problem.
Okay, thank you so much for those resources. So, Ms. Eunice, you were the one that requested for resources. Now you have 4. And I hope you're going to make proper use of those resources, since it appears you're quite new to implementation science. So I think we do have, oh, great. Oh, someone just wanted to say that the resources are not showing in the chat box. So now they are.
Yeah,
Yes.
we're getting them to show on the chat box.
Okay. Okay. All right. Thank you so much to our panelists. It's been an extremely engaging session. I know personally I have enjoyed listening to everything you've had to say. I know a little bit about implementation science. I'd like to say that I have learned a lot more, and I'm sure all of our professors on here too have learned a thing or two. I mean, we're students of life, right? We continue to learn till the very last. So thank you very much for your very, very insightful contributions, for the repositories, for everything that you have dropped for us, both Professor Emmanuel and Dr. Dr. Olabanjo. So we have clear themes which everyone might have picked up, and we have a clear understanding has been discussed as well. And today is the last day, and we're very happy that it came to a very stop or an end. If we do not have any other questions, I'd like to pull the curtain on today's session. Professor Tonya, do you have any closing statements?
Thank you. Thank you so much, Aisha. Just to say thank you to our speakers, Professor Emmanuel, thank you so much. Dr. Olabanjo, thank you. And to share this information with us very briefly, I'd like us to know that we have a conference coming up. That's the Nigerian Implementation Science Alliance has a conference coming up from between the 2nd to the 4th of September this year. It's holding in Abuja, and we would like everyone to be involved. You can register and attend virtually, but we'd prefer you be there in person. So just head to the NISA website, which is www.nisaresearch.org, and all the information about registration, whether you're attending in person or you're attending virtually, is there. And so I want to thank you to this very glorious end to 2026 NISA Research Week. And we look forward to seeing you guys in Abuja in September, or next year in the 2027 NISA Research Week. Thank you so much, Dr. Emmanuel. Awesome, great presentation. Lots of stuff that you gave us. It's awesome. Thank you so much. And thank you to everyone who stayed back right up to this time, and have a nice rest of the day. Thank you so much. Bye-bye.
Thank you. Bye-bye.
Bye. Thank you.
Yeah.